Thank you very much for the nice invitation. Unfortunately, my Norwegian is very, very basic. I think the only words I know in Norwegian is "Seg elsker dem." As far as I know, this means I love you. So I was asked to talk about basic science in cardiac transplantation. I think this could fill a whole course of postgraduate and even pre-graduate and professorship and whatever you think about. So my name is Andreas Zuckermann. I'm the director of cardiac transplantation. This is a home game for me. I'm from Vienna Medical University. And if you think basic science is complicated, actually it is, but as I'm very happy that I'm here because it's a Sunday and it's nothing better to be on a convention in your hometown on a Sunday, but actually I'm happy that I'm here because my heating system and my warm water system at home collapsed, and if you think basic science is complicating, imagine how complicated it is to get somebody to fix it on a weekend in Vienna. So of course I will share with you basic science in cardiac transplantation from a surgeon's or a physician's point of view, and I will try to tackle some of the very interesting topics that are around today concerning different aspects of cardiac transplantation. So it will be a cocktail of mind food and maybe bring you some ideas that you can take back at home and work on that. So we have a very good learning curve in cardiac transplantation over the last 25 to 30 years. This is our Vienna program results. You can see that our long-term survival now really has increased. We have had 70% 10-year survival in our patients, and even 20 years after transplantation, still 8% of the patients are still alive, so we really have come a long way. But you can see there are still patients are dying, and especially in the beginning, patients are dying, and we should work on that to even perfect our results and show everybody that cardiac transplantation is a very, very good long-term palliation. So the combination of basic science and clinical science is very important, especially in cardiac transplantation. I guess in every other field of medicine as well. There have to be interdisciplinary cooperation, and these results that you gain from the combination bench to bedside and bed back to bench side leads to a successful implementation of innovative results, and these results should increase your results and also keep the quality at a very high level. As we know, patients become sicker, patients become older, and donor grafts are definitely not the same quality as they used to be 20 years ago. So what are the phases of transplantation that are of interest? I have this cartoon here. You can see this is the time frame, weeks, months, and years after transplantation. You have the International Society of Heart and Lung Transplantation survival results, and you can see that acute rejection episodes are really a problem in the beginning, in the first weeks and months, and then the risk goes down, but it stays stable for the rest of the life of the patient. So we haven't achieved tolerance induction in our patients. Graft vasculopathy, this is formerly known as chronic rejection of the graft, or graft vasculopathy, some kind of coronary artery disease, very different to the classic coronary artery disease that you can see. This is a problem. Sometimes it is transplanted together with the donor graft, as we are taking more and more older donors for transplantation, but it mainly increases starting with year one, and the incidence really rises, and especially as our patients are living longer and longer, it becomes a problem on the long run. Complications of immunosuppression is a very important point. Immunosuppressives are very toxic drug, and we really have to keep a careful eye on that. Of course, acute side effects early on when we have higher levels of these immunosuppressive drugs, but the problems and the complications stay for the rest of the life of the patients, and the longer the patients live, the longer this toxicity can work on the patients and bring with it special problems that hit cardiac transplant patients. And there is a very important point about graft dysfunction, and it's a two-phasic problem. It's primary graft dysfunction, the time when the graft is implanted and it doesn't work as you would have imagined. So this is primary graft dysfunction. But then, of course, it goes down in almost all of the patients, even down to 0 patients have good graft function. But in the long run, it starts to rise again. And as you can see, this is a parallel curve to graft vasculopathy. And most of the patients who develop graft dysfunction in the long run develop graft vasculopathy. So this brings us in the middle of our playing field, damage to the graft and potential interventions. You have the donor graft, and of course, as I told you, the donors become older and we accept more and more marginal donors, so there are previous diseases like diabetes, hypertension that hit those donor hearts and the patients before they died and became brain-dead organ donors. Of course, age itself has an impact on the change of tissue, and a very important fact that has been newly well described and I think is one of the most intriguing and very important points where we should focus on is the concept of damage by brain death. Brain death itself produces a damage on the donor graft, no matter if it's a kidney, a liver, but especially also a heart. And to keep hemodynamics working in a brain death organ donor, you have to use drugs that also have a damage on the graft. So there might be early intervention on donor graft treatment, and of course all of this leads to the procurement and the transplantation, and during transplantation you have ischemic and then you have reperfusion injury, which is similar like in routine cardiac surgery, but of course you have longer ischemic times and you transplant a damaged organ. And then you have the different areas of the immune system after the implantation, after reperfusion, that starts to reject the organ, and then you need the specific modulations and, of course, immunosuppressive drugs, and we are quite good at this right now. And then, of course, reduced long-term graft function, because some of the damage is done early, even prior to transplantation to the donor graft or during the transplantation to the reperfusion phase. And there are people who say that within the first 5 minutes after opening of the aortic clamp and reperfusing the organ, the stage might be set for long-term graft dysfunction because of the endothelial cell damage and, of course, acute rejection. So I would like to focus, and you see through my talk, the different points that I would like to tackle, and I can only show you glimpses of these different points, and of course from a surgeon's view. So primary graft dysfunction is something that really, really hits us. It's a very underreported problem. If you talk to other fellow surgeons who work in cardiac transplantation, they never have problems with primary graft dysfunction. After the second and third beer that you drink with them, then finally it shows up and they become honest and say, well, it's a problem sometimes. And it's even a higher problem that we might think of. About 40% of the cases that die within the first 30 days after transplantation are dying from primary graft dysfunction. And there are much more patients who die not due to primary graft dysfunction, but due to the problems that these patients have a long ICU stay and might die of infection. It's every problem when weaning a cardiac transplant patient from the heart-lung machine means some kind of primary graft dysfunction. If you need high dose of inotropes, high dose of vasopressors, or if you even have such a bad primary graft function that you can't wean a patient of bypass. And in the old days, we used biomedicus pumps, some kind of assist device with a very bad outcome. Today, in Vienna and other centers, we use ECMO to wean patients of bypass, or extracorporeal membran oxygenation. And still, with all of these technical devices, survival rate of these patients is heavily reduced and is about a 56%, at the best 60% 30-day survival. So you see, these patients who develop this problem really are in a big trouble. A colleague of mine, Dr. Harinejad from our center, did a very interesting study using hypoxia-inducible factor, HIF-1A, and he used cDNA arrays taken from biopsy of the donor grafts. We use in Vienna, as a routine point, we use biopsies in the donor graft prior to cross-clamping, after cross-clamping, and then during the reperfusion period. And he could show that those patients who developed later on primary graft dysfunction defined as high inotropic support as needed for weaning off bypass or no chance to wean a patient off bypass and the need for mechanical assist. And you could see that, interestingly, after donor crossment, so still in the donor hospital, but after clamping and after perfusion with cardioplegia, there was a significant difference in this molecule in the donor biopsy compared to those patients who had good primary graft function. And it also showed up similar in the biopsies 10 minutes after reperfusion, and after 30 and 60 minutes after reperfusion, there was no significant difference anymore. So this is a very important point to show you that we might see in biopsy results, we might see in the graft even as early as prior to transplantation a damage that might show us how we can either reject hearts or not accept hearts, or that we have to modulate these donor grafts by different means. Another study that he did, it was very recently published in Circulation, also for primary graft dysfunction. This time he found in some routine biopsies that special proteins are really elevated in the blood in patients who became organ donors, that later on their grafts developed primary graft dysfunction. This was SMARCAL. SMARCAL1 is intracellular protein that acts as a DNA-dependent ATPase involved in transcription, DNA repair, and chromatin dynamics. And you can see that, interestingly, prior to, so this is the time point 1, 2, 3, the same time points as I showed. So in the donor prior to cross clamping, in the donor after cross clamping. So there's a significant difference in the blood in these in the organ donors concerning SMARCAL1. And he also did the multivariate analysis, and it was one of the very few predictable factors for primary graft dysfunction in these patients, also including some clinical data like ischemic time and some other donor factors. And this, I guess, we still don't know why this protein really is upregulated. But this might be a sign of the damage that is done to the donor organ due to brain death. And I think this is a very important fact that we should keep our eyes on and do much more work on that. There are now some brain death models in animal studies with rats and even mice that might give us more information on this very special situation and maybe potential intervention ways that in the end help our patients to have better primary graft function. Another point is more about ischemic reperfusion injury. In Vienna, we have the so-called working heart group led by Bruno Bodesser. He's doing this for many, many years, and he gave me the slides because he's working on something, the rationale for NO substitution, nitric oxide, and because if you, during ischemic injury, use exogenous NO, you might have a benefit for primary graft function in these in these grafts, and he used as an NO donor N-nitrosohuman serum albumin, and with the increase of NO used with exogenous NO, endothelial stunning that is produced by ischemia can be blocked somehow. Free oxycal radical scavenger are reduced. Thrombocyte aggregation and leukocyte adhesion, which is a very important fact for reperfusion injury, is blocked or very much reduced, and it produces some kind of vasodilation, which is a very important fact in the reperfusion phase after cardiac transplantation. And they have this very wonderful Langendorf model that they use in a routine way for many, many years. And they did in rabbit hearts 6 hours of ischemia, and he had, of course, human serum albumin as a control. There's L-arginine, which is a known protector, and he used this special NO donator in this model, where they first do the Langendorf 15 minutes, then working heart for 30 minutes, and then they used cardioplegia and this special drug with it, as a perfusate. Then they waited for 6 hours, which would be in clinical setting a very, very long time. We very rarely accept hearts that where we might have a ischemic time of more than 6 hours. And then he used a hot shot with warm cardioplagia, 50 minutes, Langendorf, and then 30 minutes of working heart. And he could prove that with this new NO donator, you have a significant better clinical setting with a better cardiac output in these hearts in the Langendorf model, much better than the control, of course, but much better than also with arginine. And he also could see that the left atrial pressure diastolic was also going much higher, was moving much higher, showing that there is better primary function of these hearts, and indirectly showing that there is less ischemic reperfusion damage. So the conclusion of this group was that this special new drug increases systolic pump function, diastolic pump function, coronary perfusion, something that we are really urging to have in cardiac transplantation, not only from the basic and scientific point of view, but as a cardiac transplant surgeon, I can tell you it's no fun to stay there in the middle of the night, 4 a.m., reperfuse the organ, and the primary graft function is not that well as we would have imagined. And also the antioxidative capacity of this new drug, the preservation of high energy phosphate, reduce MVO2, increased NO concentration, and decreased free oxycal radical scavengers. Shifting the gears, after transplantation, acute rejection is still a problem that we have to tackle, not as much as it used to be with our new immunosuppressive drug cocktail, but still patients develop problems, maybe not clinically, but below the clinical showing of these problems, there might be subclinical rejection episodes that might produce damage to endothelial cells and in the long run lead to graft dysfunction. And of course, some rejection, it's not a new kind of rejection. We always knew that it can happen. We thought we won't see it because of a great immunosuppressive drug, but more and more we learn about antibody-mediated rejection is a problem, and we need to deal with it. We need to learn more about it, and these results can only come from basic science. Events following T-cell activation, first you have the stimulus, which is very, very fast. Then you have the activation phase, expansion phase of the immune system. So plasma cells produce antibodies, T-cells divide. Then you have the rejection, which appears if you don't use immunosuppressive drugs within 3 to 4 days, and after 7 days, mostly if you don't use immunosuppression, then the graft is gone. And even if you tackle the rejection and can treat the rejection in the long run, the immune system develops T and B cell memory, which always triggers acute rejection episodes in the long run if you move down your immunosuppressive drugs. I won't go into much detail in this slide. This is mainly T-cell, so cellular rejection. Everybody of you might know that there are different signals that you need to trigger T-cell mediated rejection, and there are different drugs that tackle different areas of the signal, like the calcineurin inhibitors, cyclosporin and tacrolimus. They work in the first area on the first part or very early at the stage of a rejection episode. But interesting, there's also a fourth signal, apoptosis, which is rather the other way around. It's a more immune suppressive way of working, whereas the other three signals are immune stimulating. The take-home message is rejection is still, it's a very, very complex system. There are different interacting pathways, so nature has produced a lot of sideways that really work very well to protect a human body against the invasion of foreign protein and especially foreign tissue, which we don't like in transplantation. And immunosuppressive drugs block or stimulate these pathways. Interestingly, for I think more than 20 years, we are working on some proteins, anything that we can find in the blood that might show us a higher potential risk of rejection. I remember when I started out still as a thesis student, there was neopterin that was very well described in the late 80s, early 90s, but still we don't use it anymore because you couldn't differentiate between acute rejection and infection in the clinical routine setting. So this is something that I want to give as a point. A lot of these different proteins or different cytokines that we find in the blood or even in biopsies might be very well showing acute rejection in a basic scientific setting, but it doesn't tell you that it really in the clinical setting will give you a good predictive value. One at the very early stage, again, our colleague Aharinejad, who works in his lab in our center, he used Apollon as an acute rejection marker. As we all know, rejection is associated with apoptosis. Apollon is an inhibitor of apoptosis, and there's also another protein, RNF48, that catalyzes and degrades Apollon. And he could show that if you measure Apollon, these are different weeks after post-transplant, and at every time of these time points, biopsies are performed routinely in our patients, and you could see that high-grade rejections could be significantly detected with the help of Apollon in these patients. But you could not discriminate between low-grade rejection and no rejection. But this RNF41, this special protein, that could detect no rejection versus any kind of rejection. And as I told you, today we are dealing more and more with patients with very low-grade rejections that might, on the long run, start a stimulus of chronic graft dysfunction. A step further was the cargo study. The cargo study that they tried to discover, develop, and validate a special protocol. And this, I think, is a very interesting concept. The problem, of course, is it's a venture capital company. If there are problems in the business world, all these companies start to collapse and have problems because they don't have enough money, because there are no big companies. So very interesting new ways to approach, to detect these problems might be blocked because there is not enough money to really prove it by prospective randomized trials. So what they did, they had a phase 1 that took 2 years for discovery of candidate gene selections. So they found that 285 cargo samples tested with a leukocyte microarray. They found by database and literature mining, and they identified 252 candidate genes. And based from those 252 candidate genes, they did the phase 2, a 1-year development phase, where they developed an algorithm that was highly sensitive and reproducible by real-time PCR methods, and they developed a 20-gene algorithm to distinguish rejection from quiescence, as they said, by the diallo molecular expression testing. So it's, you take blood, you send it to the center, and they send you back the results between 0 and 3940, the algorithm, and you know at a certain threshold, I will show you, there might be a good discrimination between rejection and no rejection. At the phase 3, they did the clinical validation with 8 U.S. centers, 4 years, 629 patients, and 4,907 post-transplant encounters, and it was a prospective blinded statistical powered study. The main result in the nutshell was this test. This test was developed to identify quiescent patients. The samples below this threshold range rarely had encountered clinically relevant rejections, and samples above this threshold range had an increased probability for the concurrence of biopsy high-grade rejection. That was published in the HCT by Denk and colleagues. The main problem with this test, of course, is you have the threshold. So if the patient is above the threshold, you can't really say this patient has a problem with a rejection right now. The only thing that you can say is a good negative predictive value. So if it's below the threshold, then you're in a really, really safe area. For us, with the European thinking of with immunosuppression, how low can you go? This would be a very, very good test, because we want to lower immunosuppression as much as possible, not to poison our patients on the long run. And if you work with this test on a regular basis, then you might really individualize immunosuppressive drugs. Another point, as I told you, humoral or vascular, but the newer term is antibody-mediated rejection. Mainly published results are in kidney transplant literature, but there have been more and more publications also in cardiac transplantation. So the common principles of published protocols are similar in kidney as well as in cardiac transplantation. We're running into more and more problems in cardiac transplantation with these patients who are sensitized. Sensitization develops because some assist devices that we have to implant in the patients develop sensitization. Women who were pregnant might have been sensitized, and of course patients who had previous units of blood transfusions. And as we know, our patient population, cardiac transplantation really changes. More and more ischemic heart disease patients show up who had cardiac surgery before, and these patients mainly also had long-term blood transfusion before, and these patients might have developed sensitization. So if you want to transplant the patient who is really sensitized, first you have to get rid of the antibody in the blood to perform the transplantation, or you might immediately run within 24 hours in big problems of hyperacute or very early rejection. So you have to deplete the antibody either by plasmapheresis or immune absorption, and then you have to modulate B-cell immunity. You can try, there are old papers with splenectomies described. IVIG, intravenous immunoglobulins, might have an impact. Rituximab, an anti-B-cell antibody, is known to have some impact on the modulation, but also ATG. Some ATGs that don't have just a T cell as an immunogen, but thymocytes as an immunogen, might have also an impact on the modulation of B cells. And with that, you can prevent acute antibody-mediated rejection by the depletion of antibodies, but within 48 hours they go up again, and then during that time you have to start to modulate the immune system, and then a very, very interesting aspect shows up: accommodation of the graft. Accommodation in the setting of antibody-mediated rejection means you don't have a rejection, although in the presence of C4D staining in a biopsy and donor-specific antibodies in the blood. The rule to detect an antibody-mediated rejection are these two factors and clinical signs of rejection. So it's very, very interesting. It's quite well established, this concept, in kidney transplantation, but in cardiac transplantation, accommodation is still an immunological black box. We had a young patient after Fontan 3-4 months ago who developed such a kind of rejection, and with the protocol of immune absorption, we really could induce immune absorption in combination with ATG. We could, for the last 3 months, have a result of some kind of accommodation because she doesn't have any signs of acute rejection anymore, although C4D stainings are still positive, donor-specific antibodies are still here, but not as high as they used to be. The next point I would like to point out is graft vasculopathy. If patients develop graft vasculopathy, survival at 3 years after diagnosis is 60 to 80%, which looks not that bad, but patients who have severe disease, which means more than 40% stenosis in one or more of the coronary vessels, they have, in all 3 vessels, they have a 6% 3-year survival, where those with a single vessel disease have a 22% 3-year survival, which is really, really bad. So this disease is a killer. Death usually is due to sudden cardiac death, MI, congenital heart failure, and these ischemic events usually are silent because the transplanted heart is denervated and they don't develop angina, most of them. In the angiography, sometimes you don't see anything about this graft vasculopathy. There's still a discussion going on if the golden standard now should be intravascular ultrasound, where you can see the intima proliferation in this vessel that shows there is something going on, you're running into trouble, and you might not consider any kind of invasive therapy like stenting or dilation stenting or bypass surgery, because a lot of these smooth muscle cell proliferations run through the whole coronary artery. In some patients, interestingly, in our center, 15 years after transplant, we also find typical coronary lesions that can also be receive PTCA. Proposed mechanisms: acute rejection, ischemic time, they are different, so it's a multifactorial problem. It's the cellular consequences, of course, as I told you, smooth muscle cell proliferation that runs through the whole system of the heart. Emergent strategies are inhibition of growth factors, cytokine circulating antibodies, cell therapy, and tolerance induction. I won't go into any detail of that because there are some speakers who will talk about that. For immunosuppression, just 1-2 steps. I will skip over some of the slides. The question for us is, do we need the same immunosuppression in these different patients? Young patients, sick patients, old patients, sensitized patients. Of course, we don't need it. So I will skip over this. So we need a very individualized immunosuppression. And one of the newest immunosuppressions is rapamycin, which is a dual active drug that works as an immunosuppression, but also is the first drug that also has an antiproliferative effect that inhibits this growth factor. Vascular smooth muscle cell proliferation is the first drug that could be shown that it clinically prevented from graft vasculopathy. And lastly, some of the new concepts for immunosuppression, the idea to modify or interact in the leukocyte endothelial interaction, one of the first steps of acute rejection. So you have a lot of different factors that interact between leukocytes and the endothelial cell wall that you might stop, block, or induce that might have an impact of lower rejection or even tolerance. And of course, the role of the T regulator cells is still very speculative. They have a regulation influence on the immune system. It's a very, very small proportion, and they prevent autoimmune disease in animal models, prevent graft versus host disease also in animal models, and mediate allograft tolerance in animal models. We still right now have to learn what effect these cells have in the human body, and very interesting, in some of the last studies that have been published, it also can be induced, these cells can be induced at the higher grade with some of the antithymocyte globulins. So interestingly, this is the new use of an old drug that has been here around since the 60s, and I think it's a very, very interesting field to work in that. So in summary, there are many areas in cardiac transplantation that are well-kept secrets, and basic science is the key to give us more information. The major topics of interest is the changes after brain death. How can we modulate it? How can we prevent these effects on the organ? Ischemic reperfusion injury, especially the immunological aspects, acute rejection, especially antibody-mediated rejection, long-term graft function, how we can intervene, the development of vasculopathy, and of course, new targets for immunosuppression. So lastly, go out and bring us these results. Thank you very much.